we've seen in the last couple of years basically two treatment options that have emerged, or two targets that have been heavily worked on, which is on the one hand BTK inhibitors, which have shown tremendous efficacy in patients with previously untreated and with previously treated CLL, and also in the high-risk groups. We've seen great success by targeting this. And what we are seeing now is that this is being refined even more. So we're seeing next-generation BTK inhibitors that aim to have a better tolerability and less toxicity by avoiding some of the off-targets that a BTK inhibitor might have. So this is something that is still ongoing. We don't have overall conclusive data yet on whether we have a compound that is much more tolerable than what we have with the first-in-class inhibitor, namely ibrutinib. So this is something that is still ongoing, but certainly very interesting to improve on that. We've seen BCL2 inhibition as a very successful approach, as we've seen with venetoclax. And there are a number of other targets that are being developed. There are when you look into antibodies, you do see that there are a lot of studies working on CD19 as an alternative target to CD20. So we are starting to see data from trials using CD19 as a target. At the moment, we have mostly response data, and we do see considerable response to CD19 antibodies. We do see some studies using CAR-T approaches. The first CAR-T approaches were mainly done in relapsed refractory disease, and long-term results were not so convincing yet. However, we are seeing that with combinational approaches using, for instance, ibrutinib before doing CAR-T infusions seems to increase the efficacy of the treatment considerably. So we are again seeing an additional improvements of treatment with CAR-T cells, and this probably might be, we might see even more data on that in the near future. And we are also seeing some minor studies or phase 1 or early phase 1 studies that are using, for instance, CD138 targets or CD37 targets. So there's a broad range of different targets that are used at the moment, mostly mostly in early phase 1 settings. I think the future of CLL at the moment is going to show that we can combine several different targeted agents, similar to what we used to do with chemotherapy, where we combined multiple chemotherapeutic agents to one treatment approach, and then apply this in order to avoid resistance mechanisms and in order to achieve deeper responses. And we're seeing similar approaches at the moment. We have seen at the EHA meeting a lot of data on, for instance, triple combinations in high-risk patients, and we are seeing that, for instance, combined CD20 plus BTK plus BCL2 inhibition achieves very deep responses in high-risk patients. There are several abstracts on that, where we see that we can achieve very deep responses even in high-risk patients, which we traditionally did not usually be able, or weren't able to achieve deep responses in this particular group of patients. So we are seeing particularly successes with multi approaches in CLL.